Today we are going to discuss the ovarian diseases, in which we will discuss all type of ovarian cyst, endometriosis as well as the ovarian torsion, how to deal with. The definition is ovarian cyst is sac filled with the fluid or semi solid material either within or over the surface of the ovary. Surgery is indicated if it is larger than 10 centimeter, it varies book to book 5 to 10. If it is growing, if it is persistent, if it is irregular, if it is symptomatic. The anatomy already you know, it has ovary has three important surrounding ligament. One is proper ovarian ligament, another is infundibulo-pelvic ligament, and third is infundibulo-ovarian ligament. And the mesentery is meso-ovarian. It has mesosalpinx also surrounding. So, this is meso-ovarian, which joins with the mesosalpinx and then reflect as a peritoneum. Posterior peritoneum of meso-ovarian continue with the retroperitoneum. Blood supply, it has two blood supply, one is the branch of the ascending uterine, another is a branch of ovarian. Ovarian goes through the infundibulopelvic ligament, and the branch of the ovarian which comes from ascending uterine give three branch, one go to the uterus, another go to mesosalpinx, third go to meso-ovarian, and then both the arteries will anastomose in the meso-ovarian. Before doing any case, you must do the Ca 125, LHS, FSH, estradiol, so that malignancy has to be ruled out. Contraindication: if you have suspicion of the malignancy, it is a relative contraindication. If it is malignancy, you do not have to do ovarian cystectomy, that is a absolute contraindication, you have to do oophorectomy. Sometime when you are aspirating the ovary and enucleating it, if inside there is a cauliflower like growth, you may have to do oophorectomy. Ovarian cystectomy should be avoided. You need to either do immediate laparotomy or you introduce one endo bag and you do en bloc dissection. Patient position is simple, same like any of the other gynae procedure. Patient head should be 30 degree down. Ideally, you should stand opposite to the ovary if it is fixed. If it is mobile, you can stand on the left side of the patient. One assistant to the opposite. A scrub nurse will be there to give the instrument to both of you. Monitored, ideally two monitor, one right, another left. Or if you are using one monitor, then kept in a way that there should not be more than 15 degree head tilt. Access will be according to your wish. You can use the open technique as well as Versatile technique. If it is a big cyst, you have to go to the Palmer's point. Port position is according to baseball. If the cyst is very big, you may have to go supraumbilical, and this is the usual position of the surgical team. The monitor is placed near the right hip, coaxial alignment will be maintained. One assistant in between the leg to do the uterine manipulation. Simple surgery, first ovarian drilling. It is just a 5-minute procedure. You can put a striker mini alligator and catch the ovarian ligament, then you will go with the ovarian drilling. Tritome and 4 poles should be punctured. 40 watt maximum current is required, and just you can drill with the 4 millimeter insertion. 4-second maximum paddle has to be pressed, and that is all. Other surgery which is very useful is oophorectomy. This is a little big ovarian cyst. So, So, entry is with the palmer's point, and after that you will put one port in the lumbar, and then you can aspirate it first. Because it is reaching up to the umbilicus. So, if you will put the port in the umbilicus, there is a chance that it can directly puncture, and then you will aspirate it. Once you aspirate, you can see here, this is the deep ring, this is inferior epigastric vessel, and this is the round ligament going. So, slowly you can enlarge. Once you aspirate, the first aspiration fluid you can keep for cytological examination. You can send the syringe filled with the fluid, and then you can aspirate by suction. This is medial umbilical ligament, and this is round ligament. So, that will give you the idea. Sometime it may be multiloculated, but it is not necessary to puncture all the loculi. Once it is soft, undistended, then it is easy to manage. The fluid which has already spilled out also should be sucked, and then you can put the third port, and your target should be infundopelvic ligament if you want to perform oophorectomy. In huge cyst, especially if the patient is elderly, you should do oophorectomy. And here this is a striker mini alligator which is holding the cyst and lifting the infundopelvic ligament medially. After that, you can use either harmonic, ligation or bipolar. It is up to you which energy source you want to use, and then you can aspirate it. When you are dissecting it, you have to remain as near as possible to the ovary. This is a portion of tube also. So, this is basically a salpingo-oophorectomy, and then you can continue it together with the tube. Medial traction is important because ureter will cross below. This is uterus, and this is ovarian ligament, and here is the tube. So, uterus is small, already atrophic. You can rearrange the grasper or striker mini alligator so that the proper traction can be given, and then you can start again separating it. This is easy surgery. Oophorectomy is much easy than ovarian cystectomy. Harmonic, as you know, can seal up to 5 millimeter of vessel. So, you do not need any suturing knotting. Although, if you want, you can apply extracorporeal knot for continuous structure, and then you can cut it medial to that or distal to that, and here it is done. Oophorectomy is complete. Now, that much big ovary, how to remove? Here you can see this is infundopelvic ligament, this is ovarian ligament, and this is tube. This ovary is normal. So, now for removal, if patient already has completed the family, then the best way is to do colpotomy. You can put one sponge in the sponge holding forceps and push into the posterior fornix. Below is the rectum here. So, you can cut in the siny area 3 centimeter below. You can use hook or harmonic, and you can cut it. If you stretch it, there is no any problem of the rectum, and this sponge is visible. After that, you should not cut beyond the uterosacral. You should always keep the uterosacral intact, and the proper distension is required by the sponge, and this is the vaginal epithelium which is cut. Then this is a sponge inside. Then you can take the cyst, catch it by the claw forceps, and slowly you can bring the claw forceps in between. This is just like gallbladder extractor. and then catch it and slowly pull it out. While you are pulling it out, you have to bisect it so that all the fluid will be drained. From above you can puncture it also. If patient has malignancy, that has one of the controversy, but generally that much a small risk is always there when you are doing laparoscopy, and then it is out. After removal, just one stitch you can take vaginally and you can close the wound. You may close it laparoscopically also, but because uterosacral is not cut, so even if you close it vaginally, there is no risk of wall prolapse. If it is not necessary to close it completely airtight, because it will act as a drain, and once patient sit up, if the little fluid is there, it will come out. You can retrieve it with the abdominal wall, but for that you have to enlarge the incision, because that much huge cyst cannot be taken into the endo bag. If you have to enlarge a little bit incision. Pardon?
In case of big cysts, if we cut it into small parts of the.
You want to morcellate. Morcellation is not very much effective for the soft tissue. Morcellator does not work very nicely for soft tissue, but you can split it into two halves. You can put in the endo bag, and then you can take it out after little enlargement of the incision. That is possible. That is possible, but colpotomy has advantage that it is invisible and it is easy. Here it is a big cyst, huge cyst, and you have to confirm that it should not be malignant first by FNAC or other method, and then you will go with the Palmer's point. But even with the Palmer's point you cannot enter. This is not Palmer's point. Palmer's point is here, but actually after removal of the cyst, skin was relaxed, that is why it came up. When the cyst was there, it was stretched up, stretched down. So in those situations, what you can do, you can first directly put a needle and confirm that it is cystic fluid, and then directly you can put a 5 millimeter trocar through the umbilicus into the cyst. So first you will aspirate in the umbilicus. Bowel will rarely be above, because if bowel cannot be anterior to the cyst, otherwise patient will not come walking, and this is aspirated. Here 7 liter of the fluid came out. There is aspiration blindly done, and then you can aspirate. The patient face was shown just to make it sure that same patient is there. Now this is the punctured cyst, and here it is all the fluid which is spilled out has to be aspirated, as well as the content of the cyst. Abdominal wall will be very lax now. That will give you a beautiful vision, because it is already stretched by the cyst itself. So these cysts are basically easy to perform. Then you can again put the telescope in the Palmer's, and after that first thing you will do a lot of suction. So these all fluid will be aspirated which is spilled. You will identify all the triangles and all the 9 important structure of the pelvis. This is median umbilical ligament, which is obliterated urachus. This is medial umbilical ligament, which is obliterated umbilical artery. This is lateral umbilical ligament, which is inferior epigastric vessel. This is deep ring. Here the round ligament will go. This is inferior epigastric vessel of right side, and this is medial umbilical ligament of right. Anterior cul-de-sac is filled with the fluid. So first you have to aspirate everywhere and suck all the fluid out. Later you have to do copious lavage also to clean it multiple times. Colpotomy has one more advantage: you do not have to put a drain, because it itself is a dependent area. This is uterus. Uterus is very small nulliparous uterus. This is anterior cul-de-sac. Then you will suck from posterior cul-de-sac. After that, oophorectomy will start. You may puncture some more of the compartment if it is multiloculated, so that once the volume is small in the huge cyst, it will be easy for you to manipulate and catch, otherwise it will not allow you to manipulate it. A small bowel is collapsed because cyst was keeping them away. This is one other compartment which you can again puncture and aspirate. Sometime mucinous cystadenoma may be possible, but laparoscopy is not a contraindicated in mucinous cystadenoma. If you will search the literature, that even is a borderline mitotic type, then also laparoscopy is recommended. Only thing is copious lavage has to be done, because laparoscopy cannot be performed in these type of big cysts without puncturing it. You cannot play inside, and in those type of huge cysts, always oophorectomy is preferred rather than the ovarian cystectomy, because ovary becomes, this is tube, this is fallopian tube behind, here this is fimbria. So, care has to, in this patient we have not removed the tube. So, you can directly try to find out the infundibulo-ovarian ligament and remain in near the ovary. If you have a suspicion of mucinous cystadenoma, fertility sparing oophorectomy has to be performed, because other ovary is okay, that will take care, because if you are leaving the cyst, there is a fair chance of, and moreover ovarian function cannot also be confirmed. So, that is one of the consent you have to take from the patient, because in young girl, of course, you are correct, in huge ovarian cystectomy is not possible, because ovary become completely thinned wall and it becomes a part of the cyst. So, it is extremely difficult to remove complete cysts from the ovary. So, oophorectomy is better, because chances of recurrence also will not be there. But of course, if you can manage ovarian cystectomy, you can do, especially if it is outside the surface of the ovary. But sometimes once it develops from within the surface of the ovary, real ovary is even impossible to identify, that where was the real ovarian cortex. So, in those situations, oophorectomy is better option. So, actually if you will see in this patient, the cyst is left sided, but surgery is going on right side, because it is too huge and too mobile that you can bring it to the opposite side also. Infundibulopelvic ligament of those patients also get a lot of a stretch. Now, here we can see this is infundibulopelvic ligament. Here we are opening the wall of the cyst just to have a vision, but actually it will be cut here. The purpose of cutting it here, that allow it to go around. Here is the uterus. So, purpose was to allow to vision. Uterus is pulled up and here is the tube. Tube is spared in this case. This is ovarian ligament now. this is uterus, and here is the ovarian ligament which is cut. And now you will go little bit more over the infundopelvic ligament. Now this is infundopelvic. This is ipsilateral, yes. Actually, the target is right now we are near the right iliac fossa. The surgery is going on near the right iliac fossa, because in those patients a lot of stretch over the infundopelvic ligament is required. Now this is the last part of attachment. You have to take consent for the colpotomy also. Now it is done, and entire abdomen is, as you can see, is filled with the cyst only. In spite of collapsing it, it is difficult to pull it because everywhere there is cyst. Now you will drop the infundopelvic ligament. This is the usual port position, and here is the colpotomy. This is tube. Tube is okay. This is ovarian ligament. This is other side of the ovary. This is other side of the tube. This is a nulliparous omen, so that's why you have less space here. But in spite of that, it can be managed. The person who will be in the uterocycle will not be cut. Person who will be in the vaginal route has to be very intelligent, because he need to bisect the ovary and piecemeal morcellate vaginally. In a small pieces, you have to apply 2 cocker and then cut it, and in between you will keep on dissecting it. Otherwise, you can tear the vagina, you can lacerate it. So, this is a sponge inside, and then a sponge will be taken out, and then by the side of the sponge you will put the claw forceps. This is claw forceps. Here, by the way, this is tube, this is round ligament, this is iliac vessel. So, this is traumatic claw forceps which will pull it, and then you will start dissecting it. It has to be careful, because omentum, a small bowel or sigmoid colon should not be pulled together, because in the huge cysts there may be possible that the bowel or omentum can be pulled together. So, that is why one grasper will keep the bowel away, and this is one grasper is lifting the uterus, and slowly it will be bisected. Bisection has advantage that if any uncut pocket is there, that also will drain the fluid. You will also try to rupture, and it will easily come out, although time taking. You have to be careful. That much huge cyst, if you want to take in the endo bag, there is no endo bag of this size available. Another problem is, even if you will put in the endo bag, there will be transverse arrest, and after that it will make a bunch. So, you cannot morcellate inside the endo bag also, you have to enlarge the incision. Enlarging the incision nobody wants. Criticism is there that if there is a malignancy, it is exposed. That you have to discuss with the patient. That in laparotomy, this small risk is always there. That is why if you can do some PET scan or some other investigation to rule out the malignancy, it is always better, because suspected malignancy is a type of contraindication. And copious lavage has to be performed after removal of the cyst. With the approximately 10 or 12 liter of saline, you have to keep on washing it multiple times throughout the abdomen. Yes. This was later, once the biopsy was done, it was mucinous cystadenoma borderline. In that, the recommendation is there that repeat diagnostic has to be performed after 2 months, so that you can see the peritoneum, and if you want you can take peritoneal biopsy. So, but it is not a contraindication. You can perform laparoscopy, can be done. So, mitotic, if it is complete full fledged, not borderline, then there is a chance of myxoadenoma peritoni and other complications. So, that is why many people are reluctant of doing it laparoscopically. If it is a small cyst, you can do appendicectomy also in the suspicion of the mucinous cystadenoma with the primary origin in the appendix. So, as a gynecologist also appendicectomy has to be performed, but normally in that much huge cyst, appendix is not primary. Primary is in the ovary itself, in that much huge cyst. So, slowly it is going out, and a lot of fluid is actually draining vaginally. Now, it is almost gone, and then vaginally you will close the vault nicely, and then thorough lavage has to be performed with the 12 liter of the saline. This is the cyst, which is one completely collapsed one, which came out, and then thorough lavage you have to do repeatedly, multiple time, and then it is ultimately the outcome. Sometime you may have to do ovarian, these are oophorectomy actually. Sometime you may have to do ovarian cystectomy. If you want to do ovarian cystectomy, then laparoscopy is very good, and it is impossible to remove it always without rupturing. Here you will continue and again it is ruptured. So, a spilling can happen, and copious lavage is the answer. Like this is ovarian cyst, this is over the surface of the ovary. You can hold it by a traumatic grasper, and then you can try. This is endometrioma, which is adhered with the ovarian fossa. As you can see, if you will try to separate it, it will rupture. No, it is ruptured. So, never mind, just put a suction immediately, suck it out, dilute it. Do not allow this chocolate material to go to the diaphragm. So, immediate suction is required. Sometime you can dilute it also. And repeated irrigation will be done. Again suction irrigation, so that it will be washed out thoroughly. Now, you will hold the inner cystic layer. Sometime you can introduce the suction within the cyst itself, and then you can suck it and try to separate it. You have to be careful, blunt dissection, because below is the ureter going in these ovarian fossa. So, very careful separation is required to prevent the ureteric injury. This is uterosacral ligament, 2.5 centimeter lateral to uterosacral ligament. Here ureter goes. So, useful, and now it is separated. Now, this is a traumatic grasper. You can hold the traumatic grasper and then try to separate the cyst. You will get two wall here, it is stripped, and now this is inner cystic wall, this is outer ovarian cortex. So, after opening the cyst, then only possible is to catch it, and with one traumatic grasper inner cystic wall is held, and with the outer ovarian cortex you can try to strip it. In endometrioma, it may not be always possible to bring it as one piece. It may come in the breaking into the small pieces. So, in those situations you should try to bring it out, and if it is not coming, you will do marsupialization by burning the margins by bipolar, and the bed you can fulgurate if you think that there is some wall, portion of the cystic wall is left. Risk versus benefit also has to be kept in mind, because sometimes if you are over enthusiastic, you can damage the entire ovary. As you know, endometrioma is a bad disease which has a recurrence chance, so it should be GnRH postoperatively should be administered, and patient should be told about the prognosis, and the routine follow up is required. Many a time it is very edematous, and sometime inside there will be a small pocket of the chocolate cyst, multiple, that also has to be pulled out. This is traumatic, because simple grasper will not catch, it will slip. This is traumatic tooth grasper, that is mandatory, because if you want to do by the atraumatic, it will keep on slipping. Your grasper also may be damaged. It needs a lot of patience, and slowly you should continue. If there is little bleeding started, you should not try to coagulate it immediately. You should first try to take the cyst, after that bleeding stop itself, or at least you can find out the precise bleeder point, and then bipolar can be applied effectively. Ambidextrity is required. Sometimes you have to hold by the right and strip by the left, and again you change the hand, so that you have to walk over to the cystic wall and then keep on stripping. These are small daughter cysts which is on the cystic wall, and again entire cystic wall is coming out. In the ovary, the good thing is that cortex is outside the surface, so that you can see and you can protect its damage. Time to time it will drop, it will slip, then you have to again re-continue by holding it, and then slowly separating it by the outer. Now it is almost last part. It is not necessary to close the cyst after removal of the cyst. You do not need to suture the ovary. You have to leave it open. In open surgery, you are closing the cyst down again. In laparoscopy, generally we do not do that. Just leave it and thoroughly irrigate the inside of the ovary. it will get peritonized its own. In simple cysts, it comes out easily, but in endometrioma, it does not come this way you want in the simple. In open surgery, we have the power of our finger, which is a beautiful tactile feedback. You can get a good plane. Unfortunately, in laparoscopy, because of the loss of this type of tactile feedback, you have to be careful. Endo bag is good because that can prevent the contamination of the abdominal wall, and then you can aspirate it thoroughly. Taking it out is sometimes challenging, and if you have enlarged the incision, you must close the port because it is no more 10 millimeters. So, suture passer has to be used and close it. Now, this is the remaining ovary. Here it is little struggling to take it out. Sometimes it drops, sometimes it tears. This was a artery forceps long jaw directly percutaneously. If it is simple cyst like that, too easy, just aspiration needle can aspirate the anti-mesenteric border of the cyst. Then you can bring a scissors in the pricked area and you can open the jaw of the scissors, automatically it will split. and outer surface will tear out, then you can hold the inner cystic layer and easily it comes out by ambidextrity, because it does not have any fibrosis with the surrounding wall. It comes within 2 minutes, just you have to walk over.
Is it always better to decompress and then do cystectomy?
Generally in our practice, unless it is dermoid cyst, we always decompress. In cases of dermoid cyst, we should avoid, otherwise you should decompress. That way it comes easily, because if you will not decompress at any point of time, it anyway has to be punctured. So, unnecessarily you were struggling for 1 hour and at the end your purpose was not solved, it is already punctured. So, what is the point? Why not to in the beginning only puncture it, so that your surgery will be fast. Although in few cases you can remove it without puncturing. Now, sometime you have very huge cyst, again under vision we have to aspirate and then bring it out. In many situations, if you have an endometrioma which is not giving the wall at all, then you have to do it carefully and sometime introduce the suction into the endometrioma to irrigate and suck. Here this is endometrioma. We decided to take it out without rupturing, and this is knocking with the harmonic. Then this is traumatic grasper, which you can hold and try to separate it, the outer surface. This is knocking of the harmonic. Knocking means just you brush over that, it will make a blade and it will not puncture. So, it is not puncture, but problem is this sharp instrument, we never know. Here it is already punctured. If you try to hold it completely distended cyst, it does not work, because our finger can play with those things better, but this, so now it is better to suck it. It is sometimes so thick that it will block your suction also. So, if it is blocking your suction, then introduce the suction inside the cyst and then irrigate and suck, so that it will dilute and then it will be sucked out. Still it is leaking. So, it was decompressed, suction is outside. To clean the suction, you have to use a knot pusher and put in the suction, so that it will clean. Knot pusher, if you slide in the suction, then it will clean, because it is completely blocked. Again irrigate and suck. Now it is easy, because it is diluted, and you should keep on shaking it by holding it and do up down and then do irrigate suck, irrigate suck, irrigate suck, irrigate suck. So, dilution is the best method to control the pollution. So, you can dilute it and then you can suck it repeatedly. So, this way it is sucked. Patient head should not be down at this moment of time. Patient should be supine or little head up, so that this fluid should not go to the upper abdomen. And then again irrigate, suck, wash it completely multiple times, and now cystectomy is easy, because you have a good plane to see and holding is easy. And then this is 2 Maryland doing the ovarian cystectomy. Maryland is sleeping repeatedly. If it is repeatedly sleeping, you bring the claw forceps, 1 claw forceps and 1 Maryland is good. This is Maryland is sleeping repeatedly, then during dissection you have to be careful. This is coming out. This is again inner cystic layer. And you can separate it. Now, this is a traumatic grasper which is holding the cyst. If little oozing is there, do not do anything, just continue your surgery. It looks big in laparoscopy, but in reality it is not that much. Now it is out. Then it has adhesion with the ovarian fossa and with the rectum. So, you can try to separate those adhesions by blunt dissection and separate the cyst from the ovarian fossa also by blunt dissection. This is cystic wall which is adhered with the uterosacral. No, it is separated. Then this is fulguration. With the spatula, you will fulgurate this entire area, and the remaining any wall endometriosis has to be completely fulgurated 2-3 times. You fulgurate and again irrigate, so that this burnt tissue will be washed out. Ureter, if you want to become sure, you have to do cystoscopy, but generally most of the time the color of the urine which is coming out from the folies is one important, and another that you will be sure that you should remain towards the ovarian side, you should not strip it. Generally tearing the ureter is difficult in adhesion. It will be, if you are doing complete aggressive deep digging the ovary out, then ureter will damage. If you will keep yourself towards the ovarian side, then it will not damage. And fulguration also, here if you are in between uterosacral, there is no chance of ureter. Ureter is 2.5 centimeter lateral to the uterosacral. So, generally at that place when we do fulguration, you have to be superficial. As we know, fulguration is a coagulation current from distance. So, it has 6 times more lateral than the depth of injury. The purpose of not using bipolar is to prevent the collateral damage, and purpose of not doing desiccation, that the burn should be superficial. So, that is why it is a spray mode. Now, again irrigate and suck 2-3 times. Now, you can see almost all the endometriotic tissue is burned. This is fresh blood, so that is good. That is oozing area. Again irrigate, suck. And now you can use an interseed. This is interseed. you can spread it in dry state, then it is better. It should not become wet. That day you have seen that it was become wet while we were introducing. So, it breaks if it is wet, and always take care that ovary should be pulled up and it should go into the ovarian fossa. Both the ovaries should be lifted if you are using interseed, so that this ovary will not get adhered. So, it is lifted up.
Is there literature on relook laparoscopy in such cases where adhesions are not found?
Few of the literature of the use of the mechanical adhesive barrier or interseed has been on the animal model, but in the human any big randomized controlled trials are not there to prove the efficacy of these type of adhesive barrier. But company they themselves has sponsored few of the small series in which adhesion was not found. But any big study is very difficult to carry out. Do you know why? If it is not required, then you cannot relook. It is deoxygenated cellulose. So, it acts because it started becoming like a greasy material, and then uterus is dropped and uterine manipulator will be removed. Now, this is an endo bag. You can use a gloves endo bag, and then you can put the ovarian cyst inside it and catch both the edges of the mouth of the gloves endo bag with the same instrument, and then you can pull the mouth inside a cannula, and entire cannula will be taken together. So, pull it in the mouth and then everything will be taken together, just like how we do in gallbladder, same way. This is Veress needle for suture passer. This is Veress needle technique of closing the port. So, this Veress needle has left the one of the vehicle inside, and then it will go from other side and pull it, a loop will form, and with another grasper also you can feed it into, that is all. And then as soon as you take the Veress needle out, it will entangle the loop, and loop will be pulled by the loop itself, and here it is going out. And then outside you can tie tight knot, so that muscle will be approximated, both of them will be sutured, gas leaking will stop. So, this is a good technique. If you do not have port closure needle, you can use simple Veress needle. Sometimes you have a very bad endometrioma like this. In those situations again, purposefully, it has a fibroid also, purposefully we puncture it first. So, there is a bipolar, this bipolar is just coagulating the outer surface, and then directly with the scissors you can cut it and puncture it and aspirate it. It is aspirated. Later it will be washed again, copious lavage. And then this is the inner cystic layer, which you will separate from outer cortex, same like usual. So, can I go ahead? Because this already you know that it will be taken. Sometimes you have an endometriotic nodule, very bad endometriotic nodule. In those situations, patient has severe pain, then you have to do the deep nodular dissection, because only fulguration may not work. So, with the harmonic you can cut the deep nodules and remove it. This entire cul-de-sac has an endometriotic nodule, and ovary is also adhered with all those area. So, patient main concern is these all are patient main concern is not the infertility. Patient main concern is the pain. So, what you can do, you can strip the peritoneum with the harmonic and deep nodules can be taken out. Together you can do Luna also together, you can burn the uterosacral and you can remove these. So, this is also a beautiful procedure which can be performed, and at the end again here this all peritoneum is removed same way, one by one you will see the nodule and you will remove it wherever it is there, and then entire area is stripped out, entire endometriotic area is stripped out. And after that again you can lift the uterus, put an interseed in between and drop the uterus down. Interseed act one more way for endometriosis, it does not allow the raw area for endometriosis to get deposited again. These type of surgeries are very rewarding, patient pain can be relieved, but not guaranteed. Sometimes you have the dermoid cyst. In dermoid cyst, always it is better that you should bring one endo bag and you should put one endo bag there by the side of the cyst. This is fimbria, this is cyst. Do you know dermoid cyst has a lot of problem? I will tell you, dermoid cyst you can rupture. People they don't believe, people they don't consider it. If you will search the literature, then dermoid cyst rupture is allowed. Only thing again you have to do is copious lavage. So, if you will just put the rupture of dermoid cyst, and even the chemical peritonitis which happens can be controlled by laparoscopy itself. Redo laparoscopy also you can do. Rupture dermoid cyst of ovary, it is better to stick with the ovary, rupture of ovarian dermoid, not the brain. Mature cystic, if you see ovarian dermoid, this type of chemical peritonitis I am discussing about, which is the most fearful complication which people are thinking. If you see this literature, what it say, dermoid cyst is the most frequent benign ovarian tumor. Its intraperitoneal rupture may lead to peritoneal reaction known as chemical peritonitis. It is a rare but potential dangerous issue. Its treatment may need one or more reoperation. We report here the case of a patient, emergency torsion of the ovarian dermoid, peritoneal spillage of its content during the prolonged contact between the sebaceous material and the peritoneum was laid. The more laparoscopic intervention and systematic inflammatory treatment were necessary to relieve. We propose the following attitude to avoid complication: puncture and drainage of the cyst with a trocar, extraction of the cyst in an endo bag, and third, abundant wash out of the cyst. So, all these three precautions if you will take, you will not have the problem. And management also can be done, again laparoscopy. Now, if you will see the other literatures, most of them they say that just you have to do copious lavage. If you will add one keyword, copious lavage, copious lavage means not by 200 ml and then sucking it out, again 300 ml and sucking it out. Copious lavage means when you are doing the lavage, you should keep on doing it, just like making a pool. If you will see this type of laparoscopic torted ovarian cyst, it frequently it ruptures, and if spillage occur, complete removal of cyst contain and copious lavage should be considered. So, copious lavage will take care of itself. You have to 8 to 12 liter of the fluid, means you are converting the abdominal cavity like a pond, so that all the fatty material will float like a mud and then suck it. It is not like that 20 ml in 20 ml out, it will not work. So, this copious lavage and this you can do. So, this is very important to keep in mind, manage with the copious lavage. Here if you see 12 dermoid cysts, intraoperative spillage occur in all and managed by the copious lavage, none of them has a complication. 11 patient in a group and no patient has any complication. So, generally dermoid cyst, but I will tell you one thing. There was one video you might have seen here. This is my video. If you see the comments are not good, people they do not believe it, comments are not good, and people they pass comment if you will rupture, especially the people who do open surgery. If you see here 1,42,000 people has seen and 249 good comment, 51 bad also. Let me show you one bad. I am not concerned about the good one. I do not delete any comment actually in my channel, and I will show you the bad one. The bad one is that it is down actually, means they have said that you should go back and read again in the medical school, because see, did you ever hear that it is simply not allowed to spread dermoid cyst all over the abdominal cavity? Your technique is very good, but you should go back to a medical book. Embarrassing and very sad. I did not do anything, I just copy and paste the abstract of the article which has told that you are allowed. Laparoscopy, if you are thinking that you can operate the same way how you open, it is not possible. So, I have just pasted it. After that he says that okay, rupture it. But you know, to stop the mouth of your enemies or your competitor, it is always recommended that you keep one endo bag. But you know, in spite of having the endo bag there, you cannot guarantee that the fluid will go to the endo bag. It may not go there and it may spill it outside. So, we never have a 100% guarantee that it will not rupture. So, I will just I just showed you this literature, so that at least when we are performing the surgery, we have to be careful that you should not rupture, because the people who rupture it, they have to you cannot post it to the YouTube or all, the people they criticize, but literature they say that no, it is good, you can do that, it is allowed. There is some problem with the so, by the time it starts, if you have any question, I can discuss in the. Yes, yes, that is true. No, not lavage. In open, at least you can keep few tetras outside. Immediately, you can clean it out locally. You don't need to lavage. Do you know, if it is a rule that if anything is ruptured and I can manage, even bowel is ruptured, and if you can suture it immediately, then you should not do the copious lavage. What you should do, you should put a gauze piece and then clean it there, and with the betadine locally clean it, because if you are irrigating, then you are spreading it all over. But if a patient comes with the perforation, or it is huge already rupture appendix or rupture duodenal perforation, that means it is already spread all over the abdomen. Now, when it is spread all over the abdomen, then you have to do copious lavage, and copious lavage is not possible in open surgery, because your abdominal cavity is not a chamber. You cannot put 12 liter of 8 liter of saline inside the open surgery, even 3 liter you cannot put, because it will start coming out. In abdominal cavity, it is a chamber, so distended dome. So, if you will put it, it will work very nicely. So, that is why copious lavage is more practical in dermoid cyst. Moreover, the dermoid cyst we should do cystectomy or we should do oophorectomy, that is also one of the question. But unfortunately, in India most of the people who come with the dermoidosis, they are nulliparous, they do not have, they are infertility patient also many a time. So, in those situations you have to do the cystectomy taking care, and if the dermoidosis is more than 8-9 centimeter of the size, then ovarian function will retain or not, that is also very difficult to judge, because during ovarian cystectomy a lot of part of the ovary get damaged, but fortunately even if the 40% of the ovary works, then we can have few eggs and it can solve the problem. So, risk versus benefit we have to be taken care of. Sometime if you are trying to protect the ovary, then there will be residual dermoid, and residual dermoid is a chance of the carcinoma. Not only that, some of the patient who has a dermoid and without a good quality endo bag, if you are taking it out, and if you see the literature, a squamous cell carcinoma forms, that is a squamous cell carcinoma after ovarian dermoid, and many cases happens where the abdominal wall squamous cell carcinoma develops, but incidence is 1 in 1 lakh. So, yes, so abdominal wall squamous cell carcinoma, arising in dermoid, and if you will put the ovarian dermoid, and if you will put it happens in the port wound also, ovarian dermoid and on the port wound also. So, this also is reported. So, that is why good quality endo bag. I am not saying that do not use the squamous cell carcinoma after ovarian dermoid, port site metastasis and carcinomatosis, and after port incision and after ovarian dermoid also. So, this type of arising in dermoid, squamous cell carcinoma arising in dermoid cyst of the ovary, and then port side metastasis, this is reported. But the question is that risk versus benefit we have to keep in mind, because if that way, like sarcoma metastasis happens, as you know, in one of the patient in the USA, and then it was stopped the morcelation, but how far you have to stop it, that is still it is a controversy. So, this patient also has to be ideally explain this truth, and then you will do it. So, this is a debatable topic actually, but in laparoscopy it is not like that. Due to these reasons, just due to fear, it is contraindicated. People are doing, and thousands of dermoid is removed every day by the laparoscopy. So, what you will do, again you will go with the harmonic, you put a endo bag, so that your people will be happy that you are doing some measure, but it is not guaranteed that fluid will obey your command to enter into this endo bag. It will go wherever it wants, is not it? I cannot force the content that you must go, I have kept the endo bag, why did you go there? So, but our precautions should be there, and this is knocking, and knocking of the harmonic you can do. These are the beautiful effect of harmonic, which is not present in any instrument. Just like when you have to remove the tiles from the wall with the hammer, first you do the knocking, so that it will blab it and it will leave the plaster, and then you remove it out. Exactly same way, knocking of the harmonic can make a hydrogen bond, it will break, and it makes a beautiful blab which can be held, and then you can introduce the harmonic inside this and keep the traction away from the tissue, and with the knocking you can separate it, so that you can make a plane at least. We should try to remove the dermoid without rupturing. How far you will be successful, it is not guaranteed. You should try to use endo bag and not try to do the spillage. How far you will successful, no guaranteed. And if it is a spill, then must do the copious lavage, multiple. Chemical peritonitis incidence is very less, rare, 1 into 10,000 to 1 into 1 lakh it is reported, and that also can be solved by immediate laparoscopy and again lavage. Some people they manage it by the NSAID and steroid also postoperatively if the patient has this problem. So, but after copious lavage it is rare. So, it is now spilled and it is cut and this cystic wall. This patient is nulliparous. So, we do not have any chance of doing oophorectomy. You have to save the ovary, whatever ovary is present. This is fimbrial, another tube is attached here. This is fimbria of the tube. So, you have to be away from that. And generally, in our practice, we cut the antimesenteric border, so that it is less vascular and you can separate it in the outer cortex. And then slowly, this is a traumatic grasper, which is holding the outer surface and it is separating by opening the jaw. But the problem is there is no any instrument which can hold the distended cyst. So, anyway, the idea is to do the minimum spillage.
Sir, if there is recurrence of dermoid, because cystectomy has been done and patient comes with again recurrence.
No, generally recurrence of dermoid does not happen. That is a residual dermoid which has reoccurred. Do you know why? Because these are actually this is, see, it is ruptured here, but with the grasper you are holding it where it is ruptured. Generally, if the previous surgery has left something inside, then only it grows. So, this is residual dermoid which has reoccurred. That means, previous surgeon has not done the work effectively. So, it happens then question is,
Then what should do again cystectomy?
I think oophorectomy is better. Oophorectomy is better. Remove the ovary. So, especially if the family is complete, then we should try to do the oophorectomy better in those cases. And this is now holding we are holding at the mouth where it is trying to rupture, that is why it is not spilling. Here is the tube, this is the tube and this is the cystic wall coming out slowly. So, if you will get a complete cystic wall, then chances of recurrence is not there. Now, remaining ovary you can see it is so thin wall that how much it will work, this itself is a matter of debate. So, that is why many people they recommend oophorectomy directly, especially if it is huge. Now, this is endobag and you have to roll upon into the endobag before taking the last part. This is the remaining ovary. Now, it is entire cystic out. If you have a commercially available endobag, it is good because it has a ring, metal ring to a scoop. Otherwise, here you have to roll it like a ball. So, hold it, open it, because it is not of the size of the cyst. So, if you will try to negotiate it, it will start escaping out. So, you have to roll it like a ball. Edges has to be a little bit stretched, negotiate it, it is turning out to the other side, then again control it and bring it properly. Sometime in this type of maneuver, content keep on spilling. So, better is to use the good quality commercially, this is rolling it in and press it by the left hand, again roll it, again press by the left hand, again roll it. press by the left hand and now it goes in. Then catch it both the edges by one hand, one of the grasper, take the mouth of the bag into the cannula and then you will pull it slowly out. And here it is coming out into the cannula, and then take the mouth of the gloves outside and then rupture the cyst. And after rupturing the cyst, you will keep on pulling the hair, tooth, all the fatty content, and it takes a lot of time to remove it. And this will act as a wound protector. Your endo bag act as a wound protector, and this way you can bring it out. Sometimes you have a very bad endometrioma in which both the ovaries are kissing each other, and this uterus, posterior wall of uterus is completely adhered with the ovary, and the cul-de-sac everywhere it is completely frozen. There is a adhesion of sigmoid colon also to the anterior abdominal wall, but luckily serosa was not damaged. So, you have to contralateral port position here and one suprapubic port and two either side, and then you will try to separate both the ovaries first. In order to separate it, it will rupture, it has to rupture and it should rupture, otherwise surgery does not proceed. So, you will try to do that and see it is ruptured already. Immediately put the suction and suck all those chocolate material out, and then again keep on separating it. In those situations, this is a bipolar, Robbie bipolar in the left side, right side is a grasper and this is suction. This is ovarian fossa. Again this is the inner cystic layer. Now, it is a combination of the blunt dissection, sharp dissection, electrosurgical dissection all, because when you are pulling it out, it does not give you sometimes, it does not give way, and you have a fear that I am pulling the ovary. Then you cut it out and keep it into the anterior cul-de-sac collected there, so that at the end you can put in the endo bag all these piecemeal. So, you have to take these ovary in small pieces, and generally risk versus benefit has to be taken out. Sometime if you are too aggressive, postoperatively complete ovarian failure will be there, and if you are little reluctant, then there will be no benefit, and next time there will be very bad endometriosis. So, these are very dirty cases. You should explain the patient the prognosis that I am doing my best, but your case can reoccur. This type of endometrioma reoccurrence chances are quite high. This is bipolar, doing mercifulization, margins you can burn it, so that it will not occur again. So, most of the time in open surgery our strategy is to take the entire cystic wall out. Here strategy is to use the energy to burn the margin, so that it will be in situ, it will destroy, rather than tearing the ovary out. This is from rectum, it is adhered. Now, this is left side, again ruptured. Sometime you can introduce the suction inside this rupture itself, so that you can suck it out. Do not allow this fluid which is spilled to go to the upper abdomen, immediately suck it and then introduce the suction inside. Now, dilute it and then suck it out, and after that tear at the same place where you have punctured, and hold the inner cystic layer by traumatic grasper and try to strip the outer cortex carefully, and combination of the sharp, blunt and electrosurgical dissection has to be there. So, it needs experience. With the experience you will be able to get a plane. In the beginning of your career, bad endometrioma you should avoid, otherwise rectal perforation can happen, ureteric injury can happen. Later with the experience you will learn how to play with the tissue, and especially once your hand-eye coordination will develop with doing a lot of practical exercises, your suturing knotting develops, then it will be easy. These are the daughter cysts which punctures, these also has a chocolate material that has to be taken out. So, these type of cases are very challenging, but you can do it, and patient has benefit. Some of the patient get pregnant immediately after this type of surgery, and it is rewarding, but some unfortunate patient cannot be cured any time. Definitive treatment already you know is a bilateral salpingo-oophorectomy, means oophorectomy, that has to be done, but that is not anyway possible in the younger patient. So, I will go again ahead because it is already you seen. Sometimes CO2 laser is also done for the endometrioma. In those situations, although the use of CO2 is restricted, but few people they do. Here this is ovarian fossa and this is the endometrial tissue with the control of the suction, so that the CO2 laser cannot go to the deeper area, and you will fill up the entire cul-de-sac with the saline, so that the heat cannot pass to the rectum, and then you can do endometriosis nodular dissection. But outcome is not good. Harmonic and other instruments are much better than these type of aggressive. So, role of endometriosis, some people they advocate the CO2 laser, but majority they do not use it. Majority of us we do not use this because these are more dangerous and more traumatic. It creates more trauma to the surrounding tissue. It does not have any affinity to stop the active bleeding. If active bleeding is started, again you have to bring the bipolar, and it cuts more than coagulating, and basically it is acting by the burning. It does not melt elastin and collagen, and it does not coagulate the protein, it burns directly. So, that is why it is dangerous and it has to be carefully used. Sometimes you have the ovarian torsion, that is also a very good surgery. Ovarian torsion patients, if they come, laparoscopy is a good answer. Like here, this patient has a previous cesarean section, and after 3 months of cesarean section, she has ovarian torsion. The reason was adhesion with the uterus with the omentum. Omentum, as you know, police does not do the good thing always, they many a time do the more disturbance than the benefit. So, this is all around, and here is a tubo-ovarian mass completely and torsion. So, you have to detorsion it. In old book it is detorsion was not allowed, but those are the toxic substances, it will enter this that, but here we do not do this. Those are the old theory. So, this is detorsion will be done. So, this is contralateral port position, this is one time detorsion, this is second time detorsion, this is third time detorsion, and this is fourth time detorsion. Now, it is okay, now it is fine, but ovarian ligament is too long. So, in those cases, if you see here, I am taking a little back, see the ovarian ligament is that much long. So, this patient definitely is going, see the ovarian. So, they is definitely going to have retorsion next time again. So, better is to remove the ovarian cyst first and then do the plication of ovarian ligament. That is a very easy surgery, can be performed by the Prolene. So, you can plicate the ovarian ligament. So, next time the torsion will not occur. This is a simple cystic wall which is very easy to remove. This is a 2 Maryland which you can hold and you can try to separate it. Sometimes it is so thin that it will tearing out, especially if it is getting ischemic, then it becomes friable, but then also whatever is coming you should remove it. Hold it carefully by 2 and strip the outer. This is more edematous due to the torsion part, and it is completely viable ovary. There is no any sign of necrosis. Sometime if it is completely necrosed, you have to do, there is no option, it becomes black, then you have to do the salpingo-oophorectomy. Many patients, those type of young women comes with the just like a sign and symptom of appendicitis, and once you enter you will see the severe ovarian torsion. So, this is now the inner cystic layer which is separated, and here it is coming out. No, it is out. Then you can see the other things. Again here it was found that omentum has done some more problem here, preferably on the previous scar it is adhered, and that the way how it has made a tag around the ovary. So, better to remove all those omentums and adhesiolysis should be performed. So, you can bring the harmonic and do the adhesiolysis of those. This is done. Now, you have to do the ovary. Ovary has a very long ovarian ligament. So, catch this ovary laterally and then take a proline and then keep on taking a bite over the ovarian ligament, not on the mesoovarian, otherwise it bleeds and does not work. You have to keep on taking on the ligament itself, in the middle of the ligament. And then this is a continuous suturing. You keep on taking multiple bites. This is a single handed, because we have used only 3 ports here. This is a single handed suturing, because one instrument is just giving the traction. Take care that the ovary should not be pricked accidentally. And now bring the suture out and use a extracorporeal square knot and do the past pointing and plicate it now, so that it is now less chance of torsion. It is at least 2-3 centimeter, you have plicated it. Sometimes people are fixing with the ovarian ligament also, but that is generally done in cases of radical hysterectomy. Few more suture has been taken because it is proline. As you know, proline is not a very good suture material, because it has a tendency to slip out. So, you can take C and reverse C, and 2-3 more knots can be tightened. You can do by the vehicle, but because it is a ligament, so vehicle will absorb, then maybe it can again regain the length, but proline will not be absorbed. Now, you can do suction irrigation and you can leave it there. So, these type of cases by laparoscopy can be performed. It is again lavage, cleaning and sucking out. Now, the limit, if it is a simple cyst, retrieve it better directly. If it is a complicated cyst, always use endobag, that is advisable, and then morcellate inside the endobag by the ovum forceps or by the sponge holding forceps you can do. The limitation is that if it is a solid dermoid of that much size, you cannot do laparoscopically, which is occupying the entire cavity, because neither you can aspirate nor you can do the access with the Palmer's point, because it is completely occupied. So, these type of solid tumor you have to do the big laparotomy and then remove it. So, these are the limitations which we have to keep in mind. So, thank you very much.